than 45 years of age, who are fit serving soldiers, and who are posted in high altitude area in the Himalayas, northern Himalaya belt, that is in Himachal Pradesh to J&K, Leh Ladakh area. So they are all coming to me and being evacuated. So I had made yes. So I had made this study of 1 year duration. Aim of my study is to present experience of clinical profile and OCT guided management of these young patients less than 45 years who had presented with ACS during the study period. The study period was from October 2019 to September 2020. So I've completed around 18 months of follow-up for these patients. So this is a single center observation study. Study population is total amount participants are 119, and they are all less than 45 years of age. They have been referred to me and with ACS, acute coronary syndrome diagnosis, and thereafter I did further evaluation here, echocardiography as well as this coronary angiography for all these patients. So and proceed. So the results of the study are all these patients are male. These are all fit serving soldiers. Age range from 23 years to 45 years. So youngest patient was of 23 years age. And 71 of these patients had common risk factors. Common risk factor is being posted in high altitude area. That is more than 15,000 feet. They all were evacuated a day or 2 days later, and when they were diagnosed with ACS there. So other modifiable coronary risk factors in my patient population was history of smoking in 48 patients, that is 40.3%, dyslipidemia in 18 patients, that is 15.1%, hypertension even lesser, that is 7.5%, and diabetes only 3.4%, and family history of CAD is 2.5%. So traditional risk factors were lesser. However, smoking was still common risk factor, and other being the presence of high altitude area. So none of these patients were obese or had a sedentary lifestyle because they were all fit soldiers of Indian Army. None of these patients had prior atrial fibrillation. So presentation and CAG findings were commonest presentation in our population was unstable angina. That is in 57 patients. Overall 47.9% presented with unstable angina. Next commonest presentation was STA elevation MI. That was seen in 38.6% patients. And with further subdivision was that 68.8% of these patients were of anterior wall MI. And next common was inferior wall MI, that was in 26.1%. And 13% patient had presented with true posterior wall MI. And rest 14 patients, that is 11.7% had NSTEMI. So NSTEMI was the least common presentation. And commonest CAG findings was patent coronaries with slow flow. And most of these patients were suffering from unstable angina, and they were diagnosed with patent coronaries with slow flow. This was seen in 53.8% patients, and rest obstructive CAD was seen in 55 patients. Unique point of my study was that all these 55 patients underwent OCT study. And the distribution of CAD was single vessel disease was seen in 67.3% patient, double vessel disease in 12 patients, that is 21.8%, and triple vessel disease was least common, that is 10.9%, because these patients were young relatively and were having lesser traditional risk factors. Even diabetes was lesser. So LAD was the commonest vessel involved. That was seen in 60% patient, followed by RC in 25.5% and LCX in 14.5% of these patients. So intervention findings were that out of these, all those 55 patients who underwent angiography and were found to have obstructive CAD, 31 patients, that is 56.4% patients were having large intracoronary thrombus burden. And of these 14 patients, that is 45% of these patients out of these 31 patients overall, and 85% of patients who were evacuated from high altitude with MI, they underwent deferred stenting. What strategy I followed in these patients was that I used intracoronary thrombolysis immediately. Either through the diagnostic catheter or through the even Tiger catheter I used, and or through the guiding catheter, whatever I used. And I used either TPA 10 mg in most of these patients. And however, when TPA was not available to me, I used nictaplase with the lesser dose, 5 to 8 mg. That is 1/5 of the systemic dose. So this was followed by GP2B3A infusion, mostly Riopro infusion, that is abciximab, for 24 and next 24 hours, and then 7 days course of LMDH at the dosage of 1 mg per kg twice a day was given for all these patients. And thereafter, all these patients underwent check CAG and OCT was also done. So after following this novel approach, 85.7% of these cohort patients, these patients, that 14 patients, that stenting could be avoided, while only 2 patients required stenting after following this approach. And I've given examples, sir. I will be showing. Most of these patients had completed uneventful 2 years follow-up, and rest of the patient has completed 18 months follow-up. So all these patients will have survived a 2-year follow-up, and mortality is nil till date. No major complication has happened. That is, only 1 patient had VF after intracoronary thrombolysis, and that required DC cardioversion. And so coming to the patient examples, this is the profile of the first patient. That is a 39-year-old serving personnel, non-smoker, no comorbidities. He was evacuated from high altitude area, that is more than 15,000 feet in Leh Ladakh area. He had suffered from interval MI on 2nd of Feb 2020. ECG was suggestive of acute ST elevation MI. Echo had shown EF of 40%, and he was liaised with Nictaplase there. But however, window period was very late. He had presented to nearest medical facility after 8 hours. So pain had settled. ST resolution was there on ECG, more than 50%. Thereafter, he was evacuated to us on 3rd Feb, that is next day. So this was the pre-thrombolysis ECG, and this was the post-thrombolysis ECG. ST resolution was there, and T-wave inversion had come. So coming to the angiography, I had seen one this doubtful area of opacity is there. However, this is non-obstructive. There is a filling defect here. Most likely, thrombus is there. So this is the thrombus which is there, which has not been cleared despite the thrombolysis. RC is normal, completely normal. So what I did for this patient, I gave intracoronary thrombolysis through the diagnostic Tiger catheter only, and this dosage was 10 mg of TPA. Check CAG was done 20 minutes immediately. There was no immediate resolution of thrombus after 20 minutes because patient had presented to me very late. More than 24-hour delay was there. So he was shifted to ICCU and kept on GP2B3A infusion for next 24 hours. This was followed by 60 mg BD course of another 7 days of LMWH. So thereafter, on 10th of February, I did the check CAG and OCT was also done. These were the findings. Now the thrombus has completely resolved. The vessel is completely clear. I still wanted to be sure whether plaque rupture is there as a mechanism or not. So I did the OCT pullback also for this patient. So these are the OCT findings. If we go from distal to proximal, all 3 vessel trilaminar structure is clearly visible. There is no residual thrombus or no plaque rupture is seen anywhere. It is coming from distal to proximal. Some residual thrombus may be there still adherent to the wall. However, there is no rupture, plaque rupture. Till now, it is not visible. This is a branch. It is come. This is the plaque erosion, which I could identify, and some residual thrombus. But after 7 days, that is check NG after 7 days of following this novel approach. So further course was that since OCD revealed only plaque erosion, there was no rupture. So vessel was not stented. He was kept on DAPT for 1 year, and clinical follow-up until to now 22 months is asymptomatic. Echo has improved, ejection fraction is improved to 55%, and TMT is negative at 12.4 mets. That is after 18 months of follow-up. DAPT for 1 year and is now on, and now we have kept the patient only on single antibiotic, that is ecosprin 150 mg. Procoxant workup was done, and which is negative. So coming to the second patient, this 28-year-old serving soldier who is non-smoker, no comorbidities, and he is presented again evacuated from 15,000 feet Ladakh area, and he had suffered from inferior MI on 26 November 2019. This ECG was suggestive of acute and inferior MI with junctional escape, and EF was 45%. He was not lysed as he had come to me out of window period. So he was later on air evacuated to Command Hospital on 28th November. So his patient has continuously having ongoing angina for last 2 days. However, he reached nearest facility very late, so he could not be thrombolized. So with ongoing angina, I took him for urgent angiography, that is after 48 hours. This was an ECG on presentation to me. And this angiography, left angiogram, we see that RCA is completely filling, distal part is filling retrogradely. Littles have formed. Since this patient has come to me 48 hours now. So this thrombus was there. So I crossed with the wire. This vessel was completely occluded. I didn't take angio for this part. And after crossing the wire, you can see this is all thrombus laden vessels, completely thrombused. This was 100% occluded. So with after passing the guide wire, some flow has been restored. That is, CME1 flow has come. But thrombus, we can see large thrombus burden is there. So I did not many runs of thrombosuction for this patient. And after this thrombosuction, this was the flow I could achieve. Still, we can see there large area of residual thrombus is seen. This was the thrombus I could aspirate, red thrombus. So again, thrombosuction was repeatedly after giving 10 mg of TPA, which I followed this process. Residual thrombus was there. But even after 20 minutes of this repeated thrombosuction and 20 minutes of waiting after giving intracoronary thrombolysis, we can still see that residual thrombus is there. However, now flow is almost TME3. So I kept the patient on for deferred stenting. So OCT was also done in this setting only. Since almost TME3 flow was restored. So this, and after that check CAG was done. After 7 days, which has clearly shown that all the thrombus has been cleared. Vessel is now, there's nothing there. So only plaque erosion could be seen on OCT at this stage. So the vessel was not stented. So coming to the third case example, this patient is another 28-year-old young patient of anterior MI, who was again evacuated from high altitude area. He had proximal LD lesion of around 60 to 70% borderline lesion was there. And on various views, I could identify only this one. So this patient has also come to me after 72 hours. So I first did FFR, which was 0.84, which was negative. However, I wanted to be sure that there is no plaque rupture as mechanism for this MI. So I did the OCT. OCT at this stage clearly showed plaque rupture, and thrombus was also seen over that. So I did the PCI. For this vessel, 4 into 15 minute drug-eluting stent was done, and it was post L2 4.5. So this is the result post stenting. We could achieve good minimal lumen areas, minimal stented area. Another example where I had to stent this patient, this a 35-year-old young surgeon, again evacuated from altitude area. OCT again showed plaque rupture in this patient. This was the initial angiogram when he presented to me. He had osteoprox lesion 99%. So this was the plaque rupture was there. So I had to stent this. So I had to do left main to LED stenting, and I had to cross LCX also, and had to dilate with the 3 millimeter balloon. So this is the final port was done with 4.5, and thereafter I did this angiogram. So and OCT. So this is showing well expanded stent, and stents have been cleared from the LCX ostium also. So another example, this is a COVID positive patient, recent patient. So this is the pre-procedure and this is the post-procedure result. So this is the fifth example. Mid-RCA is showing again 100% thrombotic cutoff, and post-intracoronary thrombolysis and with TPA followed by GP2P, 3A and LM2H. This was the result, and this was the OCT image showing completely normal anatomy. So again, this patient was not stenting. So I've shown you 5 examples, out of which 2 were not, 2 were only stented and 3 were not stented. So conclusion of my study is that young ACS patient is a subset that needs to be studied for the presence of traditional as well as specific risk factors. In our study population cohort, 59.3% patients were posted in high altitude area, and approximately 40% of these were smokers too. So I found that high altitude area and smoking combination is worst for these patients. So, and with this, with the use of deferred stenting approach that I have shown in my example, case example, and after that OCT guidance, we managed towards stenting approximately 85.7%, that is 14 patients, we could avoid stenting in this kind of substrate with high thrombus burden on initial angiogram. So take home message, firstly, ACS patient FFR may be misleading. Then thrombosuction still has role in young patient with high thrombus burden, especially with delayed or no lysis. And as we have seen case example 2, there was role of thrombosuction. Imaging helps us in differentiation of plaque rupture versus plaque erosion and further need of stenting in this kind of substrate, young ACS patients. So, and in patient with severe LV dissection, still OCT can be done. However, we used less contrast, that is what 1:1 deletion was used. Thank you. Now I'm open for questions.
That was a nice presentation from Dr. Singh, Dr. Monga.
Thank you, sir.
Yes. I hope